Hello, I'm Dr. Skip Troy, Director of Continuing Education for the Clinical Foundation of Orthopedics, Orthodontics, and Temporomandibular Joint Dysfunction. We've developed a 2-year program for general dentists, teaching them how to treat both children and adults. By acquiring this knowledge, you can elevate the level of your practice and improve the quality of life for your patients. Let me show you an example of how this education can work in your practice.
Most dentists who treat children do not understand the impact of a malocclusion on the child's health. We'll look at a child that's been misdiagnosed with attention deficit hyperactivity disorder and placed on Ritalin, has a history of ear infections, was treated with tubes in the ears, was airway obstructed and actually placed on a PAP machine so he could breathe when he sleeps. You'll notice the child's head posture is out and up, which is typical of a child having to breathe through their mouth. You'll notice the venous pooling beneath the orbits. That's indicative of the maxilla being underdeveloped and the veins that drain that area being constricted. It's very difficult for many dentists to look at this type picture and see that the teeth are not the problem, but rather the skeletal, especially the maxilla, being underdeveloped. Records determine that the child's mandible was trapped in skeletal class 2, so the objective was to fully develop both arches. Once both arches were fully developed, then the mandible distracted into a class 1 relationship. You'll notice as the maxilla develops, it models both vertically and transversely out of the nasal passage, and that was a major obstruction for the airway. Once the arches are developed, the next appliance was a bionator to distract the mandible down and forward. That completed the development of the airway, so the child had a patent airway both through the developed maxilla and the repositioned mandible. So classically, most dentists will view this type situation as a dental problem, start extracting dental units, and actually make the skeletal problem worse. It's very simple to treat if one understands the underlying skeletal cause of the malocclusion. This child's had their arches developed, the mandible repositioned, and there's actually been no active orthodontic therapy to this point. So 2 things are really happening within this maxilla. It's changing in size and shape, it's modeling. And then the dental units are moving through the maxilla. That's known as remodeling. That's the osteoblastic, osteoclastic activity. In the case of the mandible, it's only the dental alveolar ridge that's modeling, with the dental units remodeling on the ridge. So you can see the overall effect of properly developing the maxilla, then distracting the mandible into a class 1 position. You note the head posture is returned to normal. The patient can breathe through their nose properly, and you can improve the quality of the child's life for the rest of his life. So I'd like to extend an opportunity for you to join us and let's help you take your practice to another level.
I hope you enjoyed that short presentation. I would welcome an opportunity to share my knowledge and experience with you to help your patients. Domo arigato. Wasame.